Welcome to Legal Nurse Podcast. This is your spot to get inspiration, tips, stories, and guidance to help you in your legal nurse consulting practice. I'm Pat Iyer, the host of Legal Nurse Podcast since 2016. We are among the top 5% of all podcasts in the world in terms of longevity and sharing information consistently week after week with legal nurse consultants. Sit back, relax, and enjoy the show. Welcome to the Legal Nurse Podcast. I'm Pat Iyer, and I have the privilege of taking you into a world today with our two legal nurse consultant guests that has high expectations when people seek out plastic surgery for either reconstruction or unhappiness with aspects of their body that they want to have surgically corrected. We know that this is a risky area, and we're going to delve into some of the liability risks today as we think about plastic surgery. Our two guests are Kenna and Grace Flack, who together have lots of experience, over 25 years combined, working in the plastic surgery area and specifically in the aftercare, after surgery. Their expertise spans the pre-op area, the consultations, the intraoperative assistance, and the post-op care, ensuring that their patients have a smooth and successful recovery. And when they are not recording this podcast with me, they are immersed in resting and nature and exploring new ways to uplift and support their patients. They have an unwavering belief in the healing qualities of a soothing bath. When my older son was about 2 and he was just beside himself, I got what I thought of as hydrotherapy, and I would put him in the bathtub and he would start happily playing with his toys and calm right down. So I can attest, as the mother of a toddler, I learned that that was a significant way to reduce stress in that child. As we transition into this area, I know that our listeners are going to be interested in knowing what are some of the expected complications that can come after plastic surgery, and with the emphasis on expected complications.
Yeah. Hi, Pat. Thank you for having us. I'm going to answer this one. I think a lot of people forget that plastic surgery is still surgery. And not just that, it's often very invasive and hard on the body. Recovery takes time. The healing process comes with a range of normal side effects. But some normal complications that we see, and one of the biggest ones is swelling. It can be significant, it can be uneven at first, and it can make one side look more swollen than the other. So that early asymmetry can be very alarming if you're not expecting it. But in most cases, it's completely normal. Bruising, another big one. It tends to show up quickly. You can look pretty, intense. Sometimes the bruising can spread. It can turn darker than people expect. Might even look worse before it gets better. But again, it's the body's reacting to the surgical trauma, and it usually fades in a couple of weeks. Pain is something that is always there after surgery. Pain really does vary though from person to person. So some people might have a different tolerance. Some people might feel tight or sore. Others can have burning or throbbing. So it really depends on the procedure, on the person's pain tolerance. Another big one that we see is numbness and tingling, which is super common, especially in stuff like a facelift. The sensations, they stick around sometimes even months. So knowing these things is really important, and that sometimes it takes a long time to heal. The key there is just knowing what is normal, what is not normal. Swelling, bruising, numbness, pain, those are normal complications that we expect to see. But we always, make sure people understand too that things that don't seem right, fevers, increasing pain, those kind of things, that they relay that to the doctor right away.
And I'm sure in patient education pre-op, you can explain these normal complications or aftercare symptoms, and patients are still caught off guard, still want to look at the mirror to say, oh my God, I've turned myself into a Frankenstein-looking creature. I've taken care of people post-op as a med-surg nurse and have seen the facial swelling, which can be extraordinarily pronounced.
Yeah, absolutely. It's really alarming, especially that first day. They get home, they look in the mirror, and they just go, what did I do to myself? So it's really nice for us to be with patients after, or clients afterwards, and to help tell them this is normal. It will fade, I promise you.
Well, and you bring up a good point, Kenna. People are not in the hospital 4 or 5 days after surgery under typical American circumstances, and they don't have somebody watching over them and reassuring them. And you brought up a good point in your answer, is that abnormal complications, abnormal signs and symptoms, which can be what ends up the legal nurse consultant is finding in looking at medical records when unhappy people seek out an attorney. Tell us about the things that are abnormal complications that could signify that somebody deviated from the standard of care.
Right. So that's kind of where we start to shift from normal healing into potential negligence. Malpractice is not about whether a complication occurred, but more of if it was something that was preventable. So there are things like untreated infections, tissue damage, nerve damage, deformities that can play into that. And when we're looking at it from the perspective of the legal nurse consultant, we're really looking to see how these symptoms were managed, or if they were even managed. And that would be then telling of whether it was something normal, or if there was, if we're going more into the area of malpractice. We actually have a recent client of ours, a concierge client, who we helped with a cosmetic procedure, the aftercare. However, she had undergone a few other cosmetic procedures in the past. And most recently, prior to this one, she experienced some really unfortunate outcomes from it. She had the cosmetic procedure. Afterwards, of course, she had, swelling and normal post-op symptoms, but she just felt like something wasn't right. And so she went for her follow-up appointment. She was having a low-grade fever. She was having, according to her mother, some changes in her mentation and just kind of not being herself, but they couldn't really put their finger on it. So she went for the follow-up appointment, and the doctor, as well as the staff at the office, told her these are all normal symptoms post-op, or especially immediate post-op. So they went back home, continued on for a few more days, and then it just worsened. Her symptoms worsened. So they decided to go to the ER, and she was found to be septic. So she actually had to be admitted to the ICU for over a week. And I mean, fortunately, she was able to recover. She was young and healthy. However, it could have kind of snowballed into a lot worse of an outcome. And so that's kind of just what we look for. There are normal effects and complications from procedures, but we have to watch out for if these symptoms are abnormal, or are they, if they're being treated, and what's being done about them.
The complications that you've described sound a lot like they are attributed to the surgeon How do nurses who are assisting with plastic surgery procedures, either pre-op, intra-op, or post-op, how could they become defendants?
So I'll take this one too. Honestly, this is something that nurses don't think about until it's too late. If you didn't directly cause the harm, even if you're in the room, if you don't speak up, if you don't document something that's questionable, you're still held responsible, especially in that operating room. You know, everybody works as a team. You know, something as simple as, you know, right now, GLP-1 medications, like Ozempic or Mounjaro, they're really becoming, you know, they're a very popular thing. Most places have a current guideline recommendation that you stop this medication before surgery for about 2 weeks. And again, this is something that it doesn't happen all the time. Last week, I just had this encounter. Client didn't hold their medication, and the surgeon and anesthesiologist, they both agreed that they would proceed with the surgery anyways. The nurse that was in the OR room, super hesitant, she voiced her concern. She came to me and asked me, you know, what do I do? And I just told her, you document everything. Because if something goes wrong, if that person aspirates or something ends up with illegal action, you know, she is at fault in that room if she doesn't document it or voice her opinion. Even if, let's say, for instance, the anesthesiologist doesn't skip or that skips a safety check, such as checking to see if they held, you know, their food and fluids the night before and check their MPO status. The nurse notices, you know, that this wasn't done, but she doesn't say anything. So that silence and lack of documentation could show that she was in agreement upon it, and it could be negligence. So documentation is critical, but so is voicing your concern. I know that, you know, being in the OR room myself, sometimes it's super intimidating to advocate and speak up to the doctors. But it's so important. To me, it is really one of the most important things, advocating for that patient when they're asleep. So, you know, document, voice your concern, and then document again.
You know, you remind me, Ken, of a man I took care of on a med-surg unit who was coming in for urological surgery. And when I asked him, when was the last time you ate? He said, oh, I had a candy bar for breakfast, but that doesn't really count. So I called the urologist. The previous week, one of his patients lied about his NPO and ended up aspirating and going into ICU. So when I called this doctor, his name was Dr. Rosen, very clear, I have a very clear memory of him. He said, I'll be right down. And he reamed out this guy and said, we are canceling your procedure. You didn't follow instructions. I'm not doing surgery on you. For the patient, it seemed like such a minor deal, but it was a big deal.
Absolutely. It's really important for everybody to be on the same page, really checking those things. And that NPO status, we see it a lot. The patient just doesn't know.
Right. They don't have that awareness of the bigger picture. And so to them, it's just a candy bar or a small or glass of water, but they're not realizing the implications that can come from that. And so that's where it's so important for the team to be on the same page, to, you know, keep that patient safe and to avoid any negative outcomes.
Let's think about a situation that you may have run into when the plastic surgeon is in the middle of the procedure and says, you know, I'm just going to do this other little minor operation while I'm here and the patient is under anesthesia. And yes, I know the patient didn't sign consent for it, but it needs to be done. I'm sure they'll be happy when they wake up and know that I took care of it. What are the implications for adding on procedures once the patient has signed, and these are being put on the consent after the fact?
So the consent is basically the holy grail of the procedure, whatever the procedure may be. What's on the consent is supposed to be what happens in the OR and during the procedure. Once the patient is asleep, there is absolutely no way for them to make that decision of whether they want to have something added on or not. And unless it's life-threatening, there should be no deviation from that. Even, to bring it back to plastic or cosmetic surgeries, we've encountered cases where a patient is there for a breast revision or an abdominoplasty, and they say they have a skin tag, a very small skin tag. And the surgeon says, oh, we discussed it in pre-op, or in our pre-op visit, that she did also say she wanted to have the skin tag removed. And it's a tiny little thing. Even something as minor as that can have legal implications for that surgeon, because it's not something that the patient, it wasn't clearly written out, spelled out on the consent that this was part of the procedure. So that's where, for nurses, regardless of which side you're on, if you're in the OR, you have to advocate and say, no, there's no consent for this. We can't do that. If the surgeon then proceeds to move forward with that extra add-on, then you're moving into legal territory. And so for legal nurse consultants, if we're looking at a case, a merit review, for example, that's what we would look for. What was on the consent? Was there anything about excising this skin tag, on the consent? You would look back at the pre-op visit also to see what was documented. But ultimately, if it's not on the consent, it shouldn't be performed. And that's a very clear line, although we have encountered many times where surgeons tend to venture into gray areas, particularly in the cosmetic world.
Interesting point. Venturing into gray areas. I envision this surgeon walking down the pathway into the dark forest and taking the turn that shouldn't have been taken, and with sometimes catastrophic results. I know that the nurses who are working in this area are also involved in doing some calculations for medications based on weight. Tell us a little bit about how that can lead to nursing liability.
Yeah, this is such an important topic, especially, well, in any surgery, but in plastic surgery. We use a lot of local anesthetic all the time. And because they're so common, people tend to think they're harmless, but they're not. Just because something is used, routinely doesn't mean it's low risk. So these medications are weight-based for a reason, and your body can only handle a certain amount based on your size. So going over the limit, that can, lead to some really bad, serious toxicity. So for example, local anesthetic, let's say the doctor has a standing order for 100 cc's of Marcaine. And so during an abdominoplasty, that's fine if their body can handle that. So based on the patient's weight, the maximum safe dose is actually only 75. So if you go over this amount or the dosage isn't right, it's not just a mild reaction. Things can actually go wrong really fast. So it's important to be exact, not just with the weight, but with the concentration, how much is drawn up, and how quickly it's given. So you can't just go off of what worked for somebody else or for a standing order. It's really the nurse's job to check the height, check the weight, do the calculations correctly, verify with your team, be on the same page with the surgeon and the anesthesiologist. And again, it's really that nurse's responsibility to recognize that and to speak up. It kind of goes back to some of our other stuff that we've talked about, but you really have to speak up to this physician. And it's not always about challenging them. It's really about advocating for the patient, checking your dosages, checking the amount that's given, documenting everything that is given, and keeping track of those totals.
I'm Pat Iyer, and I've got a question for you. Is this you? I'm not sure how to tell if a nursing malpractice case has merit. If you answer yes to that question, you might be hesitant when an attorney asks you for a quick opinion, uncertain how to evaluate the medical records or what information you need to gather. In our June 5th, 2025 workshop, we will walk you through the entire process, from the initial phone call to identifying red flags and building a sound analysis. Or this could be you. I don't feel confident about citing standards of care or finding supportive literature. Knowing the case was substandard is one thing. Being able to support that opinion about the care with credible sources is another. In our workshop, you'll learn how to identify relevant standards, cite them appropriately, and strengthen your opinion with solid research. Or this could be you. I get confused about the difference between writing screening reports and expert reports. Whether you are a behind-the-scenes LNC or serving as a testifying expert, this workshop helps you understand how your role affects your report's wording and communication with attorneys. Go to this link, lnc.tips/analyzing, in order to sign up for our June 5th, 2025 workshop being taught by myself, Pat Iyer, and Barbara Levin, an experienced expert witness. If you see this podcast after that date, the recordings of our day will be available for you and you can learn from them. Be sure to go to the link, lnc.tips/analyzing, in order to get your seat for the workshop. I'll see you there. I'm Pat Iyer, bringing to you information about our June 5th, 2025 workshop. This is a day that we have set aside to help you learn how to more clearly and more efficiently evaluate a nursing malpractice case. With Barbara Levin and I at your side, you will have an opportunity to learn how to identify the 4 elements of malpractice and how standards of care will guide your analysis. We're going to cover the difference between being a behind-the-scenes consultant and an expert witness, and what type of information you should gather from the attorney-client during that first phone call that you get about the case. We'll talk with you through a set of medical records based on a real case so that you can determine the case merits and get hands-on experience looking at the elements of malpractice. You'll learn how to use research and literature to support your opinion. What sources should you be checking out based on the issues in these medical records? And you'll discover tips for presenting your findings clearly, whether you're screening the case or you're writing a full expert report. Barbara Levin and I are both experienced expert witnesses and will guide you based on our experiences in evaluating cases. Sign up for our June 5, 2025 workshop, Analyzing a Nursing Malpractice Case, by going to this link, lnc.tips/analyzing. You'll have an opportunity to join us for that full day. And if you see this podcast after the event is over, you can invest in the recordings and get the benefit of what we shared. The link again is lnc.tips/analyzing. I will see you there. Yeah, and I think about, in particular, the pediatric patient where weight-based calculations can be crucial. and they don't have reserve to be able to tolerate something that is a increased dosage that an adult would do fine with, but a child doesn't have the ability to. And I'm sure you do some plastic surgery on children.
Yeah, we do, and it is so important, and what I have found is really being on the same page with the anesthesiologist and surgeon, to make sure that everybody understands the exact dosages, the exact amount that they can be given, and what has been given, and what they still have left to give.
I know that for plaintiff attorneys, one of the calls that they get is, I'm not happy with the result that I got from my plastic surgery. I thought that I would turn out to be beautiful, and I'm not beautiful. I just read recently in an article that men are putting artificial substances in their jaws so they have a nice square jaw. This is supposedly a very appealing look, but not everybody gets a good result from that. Is the fact that the patient's expectation not being met, is that enough to institute a lawsuit?
Not necessarily. So for that, you would take a step back and see, first of all, what is the timing on the outcome? So where are we? Are we a few weeks out from in the post-op period? Are we a few months out? Has healing fully occurred? Because really, these procedures can take anywhere from 6 months to a year to see the full final results. So you can't say for sure until your body has had the sufficient time to heal. Now, the other part to look at is the expectations and what were the patient's expectations going into the procedure. You would look at what occurred during the pre-op visit, photographs and measurements that were taken, and obviously documentation of that in the chart, because again, the chart is where you're going to go to kind of see the whole timeline of everything that's taken place with this patient. And then you can have a clearer picture as far as the legal standpoint on it. But again, the biggest thing is just waiting and making sure that enough time has passed to see if, that is the actual final outcome.
You know what is interesting also, and I'm sure you're familiar with people who form keloid scars, which could result from plastic surgery. My husband developed a keloid scar in his sternal incision from having open heart surgery, and it showed up 7 years after surgery. And I didn't recognize it at first as a keloid. We went to a dermatologist at Hopkins, and she leaned over and she looked at his chest, and she talked to his keloid scar in a very loving, friendly way, which struck me as, these keloid scars, they're just so unexpected. All of a sudden, 7 years later, they pop up. I'm thinking about the implications for plastic surgery. If you have somebody who forms keloids, can you end up with some really bad looking incisions after plastic surgery because of that as a unpredictable complication?
You really can. You see this a lot, keloid scarring, and I know a lot of times the plastic surgeon will, ask the patient, do you keloid? But a lot of people don't know. And my son actually had the same thing that happened to him. He had a scar on his chest, and it didn't keloid for a while. And the older that he got, the bigger that it got. So it is really important for, for the patient to be aware of what a keloid scar is, and that it can happen. And if the doctor if there's any revision possible for that. And Grace, is there anything that you'd like to add to that?
Well, I would just add that, of course, particularly if you're going into an elective procedure, now I know, Pat, your husband's procedure was not that, but if you're going into something that's an elective procedure, you have to understand that you are going to assume some risks by going into that. And unfortunately, something like keloids, although you can look and, if a patient has a history of having keloids with other scars and that kind of thing, or sometimes it's kind of a cultural thing too. There's, depending on a patient's ethnicity, sometimes there have a higher risk of developing keloids. But at the end of the day, you can't predict fully if that kind of thing would occur or not. And so part of that responsibility does fall onto the patient seeking out the surgery. But again, on the medical side of it, we would want to do everything possible to avoid that happening, of course. But unfortunately, it's not always predictable.
No, and he had had abdominal surgery in the past for colon cancer, and his incision healed fine. It was his sternal incision that all of a sudden decided to get red and raised and ridged quite unexpectedly. So I would concur, at least in his case, it wasn't predictable. He was going to have his triple bypass anyway, even with the risk of his keloid, and he has made peace with it. It's there. It's not going to. The dermatologist did offer to inject it or try to revise it or put steroids in it. And he said, I'm not going to win any beauty contests at this point, so it's fine. But speaking of skin disruption, one of the issues that I wanted to touch on before we run out of time is the risk of burns in the operating room. Tell us about what is put in place to avoid fires in the OR and what we might see in a case where a patient's suffered a burn in the operating room.
So yeah, burns are actually one of those complications that people don't always think about, but they can absolutely happen during surgery more often than you'd expect. So in the OR, we're working with cautery tools, lasers, and a lot of lasers these days, especially in plastic surgery. We have warming blankets, and sometimes there is open oxygen in there, all of which this can cause thermal injuries if not used properly. Grace has a story that she has shared actually on this topic before. She did a lot of education for fire safety in the operating room. And it's such a great example of how it is almost always comes down to human error, and it's not always equipment failure. So protocols exist for oxygen safety. They exist for equipment use and teamwork in the operating room. So when these steps aren't followed, patients ultimately pay the price. Burn injuries during plastic surgery, they might not be common, but when they do happen, the impact is really life-changing. And Grace, I'd love for you to share that story.
Yeah, I'll just quickly, this is a story that I think kind of pulled at my heartstrings, just being the mother of a young child too. I can't imagine having to go through this, but I've shared it many times with OR staff. And it happened in 2015. It was a young toddler, 15-month-old, up in Washington State at a military hospital. He went in for a minor cosmetic procedure. He had a benign cyst on one of his eyebrows. And so it was supposed to just be a very straightforward, easy procedure. They opted to do it as a MAC sedation. And a lot of times we think of MAC procedures, monitored anesthesia care, being safer than general anesthesia because you're not intubated. However, the fire risk with those is actually a lot higher because there's an open flow of oxygen because there's just an oxygen mask being used. So this patient, they applied an oxygen mask, sedated him, and then the surgeon was initially going to use a scalpel to excise the cyst. However, decided to switch to a cautery, a Bovie pencil. And so there was a major communication error. The surgeon wasn't aware of the amount of oxygen that was flowing. and the anesthesiologist didn't inform the surgeon of the oxygen. And so the surgeon activated the cautery, and unfortunately, there was a huge flash fire on this little 15-month-old. And so luckily, he survived. However, he did suffer major, major second, third degree burns and was in the ICU for months, has had many, many, many surgeries. And obviously, it's been life altering. So, the outcome of that case, because of course there was a legal action taken, rightfully so, it was an 8-figure settlement, and they actually admitted their fault, the hospital, and the lapses that were made. So just bringing it back, of course, as nurses, we always want to keep our patients safe. So, on the OR side of it, it's just such a reminder of all the fire risk and safety protocols to follow. But looking at it from the legal perspective, if unfortunately we were to work on a case such as this, we would again be looking at documentation, what protocols were documented, and what steps were taken to put and assure the safety of the patient, because ultimately, they're the ones that have to pay for this. And even though a large financial settlement is, that's something that doesn't change the outcome of the, everyday struggles that this child is going to have to live with for the rest of his life. So that's kind of a good story. And it always, whenever I share it, I'm reminded that it's so important.
You brought me back to an image of a boy that I went to school with who was in the garage with his father, and his father had a gas tank and he wanted to know if there was any gas left in the tank. So he lit a match and he put it down into the gas tank, and it got his son and the father full in the face. And this little boy had some reconstructive surgery, but he looked like a monster, quite honestly. There was such devastation to his features, and kids are cruel to other kids who don't look normal. And this boy had a miserable life as a result of that facial fire. So I can imagine a 15-month-old, what that child has gone through. I'd like to leave on a positive note, but that one's hard to pull out of. Let's talk about people who have listened to this podcast or watched it on our YouTube channel, Legal Nurse Business. They want to have your assistance either as behind-the-scenes consultants or expert witnesses involving cases with plastic surgery. What would be the best way for them to be able to reach you?
Yeah, so the best way to reach us, and you can reach both of us directly, is through our website. It's www.care with a K, K-A-R-E, healthsolutions.com. You can reach us at our business phone number, 949-542-0557. Or you can email us at info@carehealthsolutions.com. And we really look forward to hearing from others. It's been such a pleasure being able to be on here with you, Pat, and to be invited to speak with you today.
Thank you so much. I appreciate your time and your expertise and all the information that you have shared with us. And for you who's been watching this on our YouTube channel, Legal Nurse Business, or listening to it, please be sure to hang on for just another minute to find out who's coming up next. Be sure to go to podcast.legalnursebusiness.com for more information about podcasts that we've done in the past, or to our website at legalnursebusiness.com for a whole series of resources that we have available for you as a legal nurse consultant. And I'll see you next time. Coming up next in Legal Nurse Podcast, you'll have an opportunity to hear from a board-certified pulmonologist and critical care physician who has a special interest in evidence-based practice and in pulmonary embolism. It's my pleasure to introduce you to Charles Grodzin, our guest, as we go into these topics in more detail. Charles, what were some of the topics that we covered in your podcast?
Well, it was a pleasure, Pat. We covered evidence-based medicine. We covered some evidence-based decision-making. We covered the objective role of the medical legal physician consultant. We covered, the role of how to analyze a medical case. And we talked about elements of the standard of care in terms of how it applies in medical legal situations.
That about covers it. We went into these topics, particularly with the perspective of how they fit into our legal system in evaluating cases retrospectively in terms of whether a provider followed the standard of care. You'll have a chance to hear this podcast coming up next on Legal Nurse Podcast, and I'll see you there. Thank you for being part of the Legal Nurse Podcast audience. I'm delighted that you've joined us for this episode. Be sure to go to legalnursebusiness.com and get your free reports. Look around the website, pick up some tools that will be useful for you in your legal nurse consulting practice. And be sure to join us for the next episode.